We will continue with NICU Part 5. Okay, I want to talk a little bit about common cardiac defects. The most common cardiac defects seen in the first 6 days of life. Um, there are left ventricular outflow obstructions like mitral stenosis or aortic stenosis or atresia. There is hypoplastic left heart, coarctation of the aorta, patent ductus arteriosus, transposition of the great vessels, tetralogy of Fallot, and large VSDs or ASDs, and that's ventricular or atrial septal defects. Possible causes include environmental triggers, genetic triggers, exposure to rubella, CMV, Coxsackie B, and influenza viruses. Steroids, alcohol, lithium, and anticonvulsants are also implicated. There's also pesticide exposure. It's also seen in babies with Downs-Turner syndrome, Holt-Oram syndrome, or trisomy 13 and trisomy 18. So continuing with the congenital heart defects, the most common manifestations are cyanosis. If cyanosis occurs in the first 12 to 24 hours time and there's no apparent respiratory distress, think cardiac. Then there is also the detectable heart murmur, and then signs of congestive heart failure such as tachycardia, tachypnea, diaphoresis, cardiomegaly, or hepatomegaly. I'm going to talk about a few common anomalies. So when you look at congenital hydrocephalus, that's an enlarged head. You're going to look for enlarged or full fontanelles, split or widened sutures, the setting sun eyes, the head circumference is greater than 90% on the growth chart. You're basically going to assess for this, and then you're going to measure and plot the occipital, frontal baseline measurements, and then measure head circumference once a day. We also have the choanal atresia. That's an occlusion of the posterior nares. They may have cyanosis and retractions at rest. They'll have noisy respirations. They'll have difficulty breathing during feeding, and they'll have obstruction by thick mucus. Continuing, there could be the cleft lip. It could be unilateral or bilateral. It's a very visible defect. It may involve external nares, nasal cartilage, nasal septum, and alveolar process. They have flattening or depression of midfacial contour. They may also have cleft palate. That's a fissure connecting oral and nasal cavity. It may involve the uvula and soft palate and may extend forward to the nostril, involving hard palate and maxillary alveolar ridge. They'll have difficulty in sucking and expulsion of formula through their nose. They may also have tracheoesophageal fistula. That's a connection between the trachea and the esophagus. There's usually a history of maternal polyhydramnios, excessive oral secretions. They can have constant drooling. They'll have abdominal distension beginning soon after birth. They can have periodic choking and cyanotic episodes. They'll have immediate regurgitation of feeding. Clinical symptoms of aspiration pneumonia, such as tachypnea, retractions, rhonchi, decreased breath sound, cyanotic spells, or the inability to pass nasogastric tube. We also have the potential for the diaphragmatic hernia. This is a portion of the intestines in the thoracic cavity through abnormal opening in the diaphragm. They'll have difficulty initiating respirations. They can have gasping respirations with nasal flaring and chest retraction. They'll have a barrel chest and scaphoid abdomen. They may have an asymmetric chest expansion. Breath sounds may be absent, usually on the left side. The heart sounds are displaced to the right. Spasmodic attacks of cyanosis and difficulty in feeding, and they may have bowel sounds that can be heard in the thoracic cavity. We have the omphalocele. That's a herniation of the abdominal contents into the base of the umbilical cord. They may have an enclosed transparent sac covering. They could have gastroschisis. This is a full thickness defect in the abdominal wall, allowing viscera outside the body to the right of an intact umbilical cord. There's basically no sac covering. Intestines are exposed to the caustic amniotic fluid associated with intestinal atresia and malrotation. We also could have prune belly syndrome. It's a congenital absence of one or more layers of the abdominal muscles. You can have oligohydramnios leading to pulmonary hypoplasia, which is common. They have the deficiency of the abdominal wall musculature, causing the abdomen to be shapeless. Skin hangs loosely and is wrinkled in appearance. It's associated with urinary abnormalities such as urethral obstruction. In males, cryptorchidism is common and it rarely occurs in females. We could have myelomeningocele, that's a sac-like cyst containing meninges, spinal cord nerve roots in the thoracic and or lumbar area. Myelomeningocele directly connects to the arachnoid space, so hydrocephalus often is associated. There's no response or varying response to sensation below the level of the sac, and they may have constant dribbling of urine, incontinence or retention of stool. Anal wink or may not be present. They may also have the potential for imperforate anus, a congenital dislocated hip, and or clubfoot. This concludes part 5 of the NICU.